Good afternoon. Thank you for joining us for this meeting of the subcommittee of the West Yorkshire Joint Health Overview and Scrutiny Committee, looking at vascular service reconfiguration across West Yorkshire. At the moment, this meeting is informal as we are not quorate, but we will continue with the discussion of the matters before us, pending the arrival of more committee members. So to start off with, can I ask people to introduce themselves in turn? My name's Colin Hutchinson, I'm Councillor for Skirkett Ward in Calderdale, and I'll be chairing this committee. Councillor Smage.
Councillor Liz Smage from Kirklees Council.
And Councillor Clark.
I'm Councillor Jim Clark from North Yorkshire County Council.
Councillor Godwin.
I'm Councillor Paul Godwin, Keighley West in Bradford.
Amy Campbell.
Hi, Amy Campbell, Communications Manager for Wyatt.
Thank you. And Matthew Groom.
Hello, Matthew Groom, Regional Director of Specialised Commissioning for North Eastern Yorkshire for NHS England.
Thank you. Thank you. Welcome. Sarah Halstead.
Hi, Sarah Halstead, Head of Specialised Commissioning for Yorkshire and Humber, NHS England.
Thank you. You'll forgive me if I ask people twice because the names are flitting around on my screen. So apologies if that happens. Caroline Coombs.
Scrutiny Officer, Bradford Council.
Thank you. Claire Vickers. Do we have somebody called Claire Vickers here?
Claire, you're on.
Hi, can you hear me?
Yes.
Hi, Claire Vickers, Head of Nursing for the West Yorkshire Vascular Service.
Thank you. Jill Galt. It's Jill Galt here. Okay. Helen Gray.
Hello, Helen Gray, Scrutiny Support Officer for Leeds.
Thank you. Jane Lang.
Hello, I'm Jane Lang. I'm General Manager for the West Yorkshire Vascular Service.
And of course, Niraj Basin.
Hi, Niraj Basin, Consultant Vascular Surgeon and Clinical Director for the West Yorkshire Vascular Service.
Thank you. Apologies to anyone that I've missed out, but it's quite tricky to follow when the tiles keep moving around. Right. Well, hopefully we've all had a chance to look at the fairly extensive papers that have been submitted with this agenda, and I was wondering whether there were any specific matters that Mr. Groom or Mr. Basin would like to bring to our attention in addition to what's been set out. Otherwise, I'll put it over to members to ask questions. Matthew Groom.
Yes, thank you. Just to update on since the paper was submitted. So obviously the NHS is in a response to COVID, as you can imagine at the moment. So we have a lot of focus on that at the moment. So we've had a lot of discussions with the hospitals about the go live and when to actually move forward with this, which wasn't at the time of the paper being submitted. We hadn't actually got to that position. But I wanted to update the members today that we are planning on a go live date of the 16th of November. And we have the support of the providers to go ahead with that. And from the discussions we've had, it does feel that that is a sensible time to go ahead and to move forward with the changes, and also makes the service sustainable as we go into winter period. Now, obviously that's pending any challenges that may happen over the next week, but that's the current plans that we are working to. So we are planning to, after today's meeting, we are planning to start to inform the wider system and the GPs, etc., and patients that these changes will be moving forward on the 16th, obviously pending any other issues that may cause us having to delay. But we're confident we can proceed on that basis.
Thank you very much for that clarification. So there were a number of issues that we'd asked for confirmation of at the last meeting prior to go live. So I was wondering if members had any questions as to whether they were happy with the information that we now have in front of us. So, Councillor Smage.
Thank you. We were going to receive an update as to whether therapists across the network were in place to plan and make the necessary arrangements. Are we saying that those therapists are available now, please?
Mr. Bassine.
Thanks, Councillor Smage. So there is a active recruitment post advertised at the moment for a therapist, and what we have is an interim arrangement where the therapist based at CHFT will support the service in Bradford post-transfer until recruitment has been completed. So there is an active advert out, but there is an interim measure in place with therapists supporting across the system.
Thank you.
Can I come back for a second question?
Please do.
On your list of pathways, there's are the consultants going to the patient, or are the patients going to be transferred to the centres with the consultants? Just if you could just clarify that, because it looks, in one particular case anyway, that there would be transfer to what's called the arterial site.
So given that all the operating resources and post-operative care resource would be within the arterial centres, and just remembering that these pathways are created for the whole region, including Leeds and Mid-Yorks, that the default position would always be that any operative care or high-risk intervention radiology care is delivered at the arterial centre, and therefore the patient would be within the arterial centre. There are those very rare occurrences that where in an emergency situation, if a patient cannot transfer, then the surgical team or radiology team would transfer. But that again is a very rare occurrence. But ordinarily, the pathways are set up to deliver care within the arterial centres.
Okay. Can I just ask a question about the pathways, please? I just wondered how these are going to be accessible to clinicians in primary and secondary care, whether, in what formats. They won't be in a box file that somebody will have to riffle through to actually find the appropriate pathway for the patient that they want to refer into the service. How will they be able to get that information up front?
So the plan, as Matthew described, is with the communication that will go out to the CCGs, the clinical pathways will be part of that bundle from NHS England that goes out, accompanied by a letter from me as the clinical director and my contact details, and therefore it will then be disseminated through the CCGs. That's how it'll get to the CCGs. In terms of the individual trusts, we have operational groups set up in all the individual trusts, and these documents will have and will be passed into these operational group meetings for the individual trusts to disseminate through to all the relevant clinical and non-clinical teams. Finally, what we will also be doing for Go Live is creating a website. So there is a central electronic resource where these pathways are available to clinicians as part of their, probably as part of their own intranet arrangements. So that's how we would plan on disseminating the pathways to primary care and secondary care.
Thank you. Thank you. Councillor Smage.
Thanks. The network arrangement between Bradford and Calderdale and Huddersfield, can you let us know where we are with that? And can you also let us know where you are with outcomes from discussions with the Combined Authority and Bradford and Leeds Teaching Hospitals regarding travel and parking arrangements, please?
I'll happily defer the travel and parking question to Matthew. However, just to let you know that in terms of the non-vascular interventional radiology, there is a executive-led, so at Chief Operating Officer level and Medical Director or Chief Medical Officer level agreement where they have worked with the non-vascular interventional radiology teams, where there is agreement that during daytime hours, working hours, non-vascular interventional radiology emergencies will be dealt with locally. Out of hours, they will be dealt with through Bradford, and they have designed pathways, for example, a gastrointestinal bleed pathway through which there is an escalation route of a treatment escalation route, but also communication routes. The thing to reassure you that the pathway identifies that this will be a consultant-led decision. So it will be consultant to consultant discussion between parent teams to ensure that all options have been exhausted, that transfer is required and that it is done in a safer manner as appropriate.
If I pick up the transport letter,
please.
so we've written twice now to the West Yorkshire Combined Authority, and we've had no reply. So if members are able to help with any way in, that would be really appreciated, because we are struggling with a contact into that body. In terms of the two trusts, though, we've had responses now, as in early this week, both from Bradford and from Leeds, which I can report back to you now verbally. Bradford they've reiterated their commitment to having more virtual appointments to stop people having to travel generally into the site, which will help on demand of parking, and also their commitment to people having their diagnostics close to home wherever possible, so they don't need to travel into the site. They've also been having a big push on their own staff home working wherever possible, which is having a positive impact on freeing up car parking spaces. And with the new hospital wing, that's created 50 additional spaces as well. In terms of Leeds have confirmed that as part of the new £600 million build, there is a multi-storey car park going to be part of that. They do acknowledge, though, that transport can be difficult at the Leeds site, but there is good transport links around the city for people to use, and parking is available across the site and also nearby as well.
Thank you.
Can I just double check about capacity for these changes? Is there capacity in the system to make these changes at this moment in time? So you're confident that you will be able to meet your date? There is capacity to do that?
Just clarity to clinical capacity, bed capacity. Yeah, so we have a weekly meeting that's led by the Chief Exec of Bradford, where the Airedale, Bradford and CHFT Chief Operating Officers are present. As currently, due to COVID, we are doing acute operating. The numbers of inpatients are small, and therefore we believe and we are assured that there is the capacity to accommodate the changes, not only the bed capacity, but also the theatre capacity currently to sustain the level of acute demand that we require. Clearly, because of the wider issues, we're not currently, there's not a wider inpatient base or wider elective routine operating. So there is the capacity.
Can I ask, Matt, who if we do manage to get in touch with somebody in the West Yorkshire Combined Authority to take this forward, whose address should we give them to be? Is it yourselves, or would it?
Yes, it'd be me. If they can contact me, it would be probably easiest.
Yeah, can I just come in? I thought we'd given yourselves the name of the WICA chief officer to contact. Are you saying that you've not had a reply from the chief officer that we've given you already?
Yeah, we've been in touch twice now with the authority. I can check if it's exactly that name, Councillor Smage, if we've actually used. My understanding is that we've contacted the organisation twice, but I will double check on that name. But any other way in would be helpful for us as well, really, absolutely.
Okay, I'll try and get that sorted for you.
Thank you.
Can I ask? I mean, one of the principal drivers for this reconfiguration is workforce. So in the report back, you said recruitment of surgical consultants are in the process of being concluded. What does that, having been through that process dozens and dozens of times before myself, I just wondered what stage that actually meant, whether the funding was there, whether the jobs had gone out to advertisement, whether an interview date had been set. At what point are we?
So in terms of vascular surgery consultants, on the 27th of October, we interviewed and appointed 2 further consultant colleagues.
Right.
In terms of interventional radiology, we had appointed 2 consultant colleagues already, but unfortunately one was an overseas candidate and due to their situation has withdrawn. So we have 1 further interventional radiology consultant colleague. And finally, in terms of a comment, I think both from yourself and Councillor Godwin was, especially around IR, was trainees. As of Monday, well, as of yesterday, we have agreed the funding for 3 interventional radiology trainees locally to do an extra year's training within the region. So therefore, to sort of quote a phrase that I think one of you used, which is to grow your own and then hopefully retain our own. Because of the extra year, each one of those 3 trainees will have a 4-month block outside of Leeds within the Bradford, Airedale, Calderdale network side. So they will also get experience of working outside of Leeds. So then hopefully give them exposure to this part of the network, and therefore hopefully turn trainee colleagues into consultant colleagues. So we've managed to do that as well.
That's great. Do you think there's any prospects of that becoming a continuing feature?
What I would say is that actually, as you know, interventional radiology is a really pressurized specialty. We have reacted to a demand positively. I expect that if we had the opportunity if there were the number of trainees who were wanting to do that, I cannot see that we would necessarily shy away from that opportunity again, knowing the numbers that we need within our region. But certainly what we've done at this point is react quickly to an opportunity that was there.
Yeah, I mean, that's it. That's very welcome news that the funding is now in place. So thank you for that. You say again in your report that home visits by district nurses and therapists will that there are remaining issues around home visits, because obviously those are going to be crucial to the continuing care of people, to the continuing flow of patients through the service, to stop it from getting bottlenecks from developing. So what are those remaining issues, and what can be done to resolve them?
So the issue out there, again, just picking up on a point that Matthew made, is that this was at the time of the report. The issues were about if a patient, for example, had had an amputation, would it be the therapist from their base organisation that would go out to do a home visit to look at access and safety, or would it be from the arterial centre from Bradford? What you can see that we have therefore resolved and created, and we've given an example of, is an agreed therapy pathway. The example we've given you is the Kirklees one, but there is an identical bespoke discharge pathway and arrangements that has now been collaboratively created by therapists from across the region, which comprehensively covers and details all the contact points, requirements, flow charts, requests that would need to go in for each locality, and therefore those issues are now summarised within that. As in, that's the resolution, is the package that we've provided you with that details how to access all of those documents, resources and organisations.
So there's a similar set of documents for Calderdale. So I was just slightly concerned that these things were all in place in Kirklees.
No. So there is for Bradford, there is for Airedale and Craven, for Calderdale. It's just because they have to be bespoke, because we didn't want to send you 5. We just sent 1 as an example. But yes,
that's understood. Thanks. Is there? All right. If there's no one else who wants to come in, there was just a couple of other questions.
I was going to say, what about the nursing capacity and the nursing workforce? We've talked about clinicians, but what about the nursing workforce as well?
So because obviously currently we're working on a compressed bed base, because of COVID, we are not implementing instantly the planned 39 beds. We are going to utilise the core existing vascular ward, because again, we only need a smaller bed base at this point, and we're assured and have seen a workforce model from Bradford, and there is because we're going on to an existing ward, there is the existing nursing cover on that ward.
The assumption is that the majority of people will be following their treatment at the arterial site will be discharged to their own homes rather than into intermediate care or to Calderdale or Kirklees Hospital. Healthwatch England produced a quite concerning report last week about the discharge to assess process, how large numbers of people who were discharged to assess never got an assessment, or there were long delays in those assessments actually taking place, and that a third of the patients weren't sure, didn't know the result of the COVID tests that might have been done in hospital, which obviously if they're having carers coming to the home or they're going home to a family where there's potentially vulnerable people in it, those results ought to precede them almost. So if there's going to be a lot of reliance on discharge to assess within this process, how can we make sure that it's as streamlined as possible? Because I notice on the aids to daily living, or that it required that they're asking for a 5-day turnaround for equipment to help people being looked after at home. If people are discharged with a delay then to the assessment as to what support they need, and then a further delay in getting access to the equipment, it does leave them in a bit of a hiatus. And I just wondered how, and they also again, with the Health Watch England report, it said a lot of people were discharged without any contact numbers, so that if they were running into clinical problems or care problems, they didn't know how to get back to the clinicians who had been, the clinical team that had been treating them, to try and make sure that those problems are picked up. How have those concerns been addressed, or how can they be addressed?
So as far as I'm aware, being on the ward regularly, all our patients have a physiotherapy and occupational therapy assessment where appropriate prior to discharge. As you know from your experience, the majority of our patients have lower limb surgery or major abdominal surgery, and therefore will do things like routinely a stair assessment before they go home to ensure they are safe getting up and down the stairs. If they have had surgery that affects their upper limb, they will have an occupational therapy assessment to ensure that they are safe to make a cup of tea. So as far as I'm clinically aware, those safe for discharge, or as we're describing it, therapy fit for discharge assessments are done pre-discharge. And as we're working on a smaller number of patients currently, I wouldn't expect any change in that practice.
And do they all get given a telephone number to ring if they're running into problems?
I know that they did with the reconfiguration of wards in response to COVID. That's a point that we will take and ensure that people do when they are discharged from Bradford. I know that's certainly something we did do, but again, because the wards have moved and patients have been cohorted, currently I'm not sure that practice is still continuing, but we'll make sure it does.
You'll be relieved I only have one other question. It's about the Yorkshire Ambulance Service. Are they going to be trying to identify people with acute abdominal aortic rupture, or who are in the process of rupture, or ischemic limbs, and taking them straight to Bradford Royal Infirmary? Or are they still going to be taking them to Calderdale or Huddersfield hospitals for a state assessment and stabilisation before taking them on to Bradford Royal?
So obviously with our current alternating arrangement, in any case, the arrangement is that if a paramedic or ambulance crew feel that someone has an abdominal aortic aneurysm that's symptomatic or ruptured, or an acute limb ischemia, they would phone their control centre to determine which arterial centre was on call, and then take them directly there to avoid any delay in their treatment. So what will happen is that if they identify a primary vascular emergency, they would take the patient directly to the arterial centre for speed.
Good, good. Thank you. Right. Do committee members have any other questions?
I just had to comment. I thought the transport part, which we've touched on, the documents dealt with very well with our concerns, aside from the points that you and Liz have made today, really.
I fully agree. I think they're admirable. Councillor Clark, have you got anything you'd like to say? No? No. Okay. Councillor Smage? Right. Well, I think although this, from a formal point of view, this committee is in quorate, I would like to say that from my point of view, the documents we've received and the responses to the questions have satisfied myself that this project is ready to go live on the 16th of November, and that you've covered the concerns that we might have had. Does that reflect the view of the other participants? And Councillor Godwin is nodding.
Yes, I think so. I think we need to thank people for coming today. We realise it was, it's a difficult time for everybody, isn't it? But thank you for your time. I think, but I think if we're going to have if we need any further updates, then can I suggest that the West Yorkshire Main Committee takes and North Yorkshire Main Committee takes it on?
Yeah. No, that would be that's the intention, that this committee would dissolve itself once we have a formal mechanism of doing that. And I would like to thank all the clinicians and all the representatives from the various organisations for the help that they've given this committee, and the work that they've done over the past year or so in getting this project on the road. And I wish it all the best and hope that it delivers the aspirations that you have and provides a sustainable solution to vascular services in West Yorkshire. So good luck to you all. So thank you very much, and I'll call this meeting to a close then, and we will complete the formalities outside of this meeting.
Thank you.
Thank you.